Hello, I'm Dr. Jon Perlin, Chief Medical Officer and President of Clinical Services for HCA Healthcare. On behalf of our CEO, Sam Hazen, the senior leadership team, and myself, I want to thank each and every one of you for everything you're doing to help us meet the needs of patients, colleagues, our community, and HCA Healthcare during this extraordinary moment as we approach the treatment, management of this worldwide pandemic. I want to thank you as well for your leadership in the important role of being bearers of knowledge, of fact. There's a lot of misinformation out there, and you have an extraordinarily important role not only as care providers but also as leaders in sharing the best information as it affects how we treat patients both with and without COVID. We know that this unprecedented situation is changing how we receive and evaluate patients, how we segment patients to treat those with COVID or suspected of COVID, as well as the patient flow and activities for patients without COVID, how we protect ourselves, other clinical staff, and importantly, patients. Thank you for your leadership in all of those regards and being leaders in spreading the best information to provide the very best care. By virtue of its scale, HCA has extraordinary access to the best scientific and information resources in the United States and indeed the world. Our CEO, Sam Hazen, is on the White House Task Force, and we are tightly connected with the Department of Health and Human Services at all levels, from the Secretary on down. And that gives us some insight into what's changing in terms of guidelines, what's known in terms of reconnaissance. We're also connected to leaders in private sector. Indeed, we're working closely with leaders of the largest payer organizations and of the largest lab organizations. We know that you're facing challenges such as the access to COVID testing and the delays in turnaround time in COVID testing, and we're working on a project to accelerate that for hospitals. Reciprocally, by virtue of our scale, the privilege of nearly 35 million patient encounters each and every year at 2,200 sites, we're an important point of information for the Centers for Disease Control and other elements of HHS as they develop their monitoring of hotspots and indeed their modeling for what may happen across the country. And so thank you for being a part of this important system. Our goal today is to give you the most current synthesis of information as we know it, to share what we know about the epidemiology of care at this moment, to provide the best authoritative clinical guidance that synthesizes many sources and is absolutely current as of this moment, and to provide some insight into what we're doing across HCA to manage these unprecedented circumstances in managing a pandemic at the ground level of patient care. To do that, I'm privileged to be here with world-renowned infectious disease specialist and epidemiologist, Dr. Ken Sands, who also happens to be our Chief Patient Safety Officer for HCA Healthcare. We were pleased to steal him from Harvard's Beth Israel Deaconess Medical Center about 3 years ago, where he had a number of leadership positions, including serving as their Chief Clinical Quality Officer. And he really grew up in the Harvard Beth Israel system, completing his fellowship in infectious disease and epidemiology there, as well as his residency. He's a graduate of Dartmouth Medical School, but most importantly, let me tell you this. He's a clinician's clinician. He's extraordinarily practical as a healthcare leader, and he's incredibly accessible in terms of helping us get to the ground truth in terms of what we need to know to take care of patients most effectively. So I'd like to welcome Dr. Ken Sands.
Thanks so much, Dr. Perlin, and thank you all for joining us for some time today, and thank you for all you're doing to take care of patients across our enterprise. Our goal today is a mini grand round, maybe about 15 minutes, where we're going to cover some of the basic science around COVID-19, some of the science around infection prevention, and then how we're putting that into practice here at HCA to protect yourselves and protect our patients. So all the data that you're going to see is very fresh. We are trying to keep up with the science here, but at the same time, the science is changing. So please know that the information may change, and our commitment to you is that we will be updating you as that information changes. This is the backdrop of the situation we're in. We're in here largely because of large shifts in population. The population is moving into more concentrated centers, and at the same time, mobility is increasing. That's what these slides show. And so this creates more opportunity for the sharing of new pathogens that arrive into the human population from other sources. If you go to the next slide, we can show you that this is how it's looking in terms of the COVID-19 spread across the United States. This slide was made a couple of days ago, and that number of cases being greater than 4,000 is now more in the range of greater than 8,000 as we sit here today. You can see that there are some centers of population that are experiencing more significant outbreaks. The Northeast, New York City, and the Massachusetts area, San Francisco, and also Washington have been particular hot zones, if you will. Within HCA, we are also tracking the occurrence of cases and seeing similar increases as there have been across the United States. This is data that just goes back to the first part of March 8th, through to yesterday, and we are tracking in-house cases of persons under investigation, or PUI, as well as confirmed COVID cases. And you can see the dramatic increase we are seeing in individuals identified as PUI, as well as an increase in COVID cases, which we fully expect to become more dramatic as testing becomes more available across the enterprise. Coronavirus is a single-stranded RNA virus. It gets its name by these little crown-like postings it has on its membrane. It's a member of a family of different viruses, and these viruses, coronaviruses, typically live in an animal reservoir. Many of them in the bat population, which carries coronavirus as an asymptomatic carrier state, and then they reach humans probably mostly through a intermediate host. Camels and civets have both been identified, but there may be others. So with increasing interaction among the human population and with different animal populations, we see the opportunity for spread of these new pathogens. COVID, when it's being spread from person to person, has an incubation time probably of around 5 days. There's some variability around that. But most people, if they are going to exhibit symptoms following exposure, will do so within 11 days or so. But in terms of when we are managing strategies of quarantining individuals, the recommendation from the CDC is to take that out to 14 days because of the low but possible likelihood that incubation could be that long. There's some information here on this slide about what's called the R0, which is a measure of ability of the virus to be transmissible. That number for COVID is felt to be around 2.2, meaning that for every individual with COVID, another 2.2 individuals will get it from that individual. You can see the range of R0 for some things like measles, which is highly contagious. 12 to 18 people will get it for every individual with measles. Influenza has a little bit of a lower R0 than COVID at 1.4 to 1.8. So this is a fairly transmissible virus, although not as extreme as something like measles. The clinical presentation can be variable. It's believed that there's a large population, perhaps as many as 80% of those with the virus that have very mild symptoms or no symptoms, or it can be a more severe respiratory disease. The majority of patients have fever, but not all. The majority have cough, but not all. Typically, myalgias and shortness of breath might be seen as well. The X-ray and the CAT scan may have a typical ground glass appearance to it. Interestingly, lymphopenia is a common finding, and as we've said, many will just have a mild disease. Here's an interesting table that just goes through some of the differences, and we get a lot of questions about how do I tell the difference between COVID presentation and just the sniffles or allergic reaction. And you can see that there are some things that are unusual with COVID-19, such as a runny nose or sneezing. These are not typical findings with COVID-19. And that can help you make a differentiation between just what might be a more common respiratory syndrome and COVID-19. So we're going to talk a little bit about testing, and this has obviously been a very active area. We've put together some guidance, and a lot of these materials are available through our Atlas webpage, which we'll talk a bit more about later. But we have recommendations that parallel what has been written by the CDC and have been designed to address the different testing strategies. Our testing strategy is partly influenced by the fact that opportunities for reference labs is now just starting to come online, but the turnaround time for those reference labs may not be any faster than going through state labs. These are things that are changing rapidly, but the key point for now is that the population that should be tested currently is those with symptoms and those that have the level of illness that they are requiring hospitalization. For our population, that is the group that we are suggesting testing for. People that have mild symptoms or no symptoms should be at home getting advice about care from their personal doctors, but not coming to our facilities to get care in those settings. It's certainly not to the emergency department or inpatient settings. If you go to the next slide, you can see we have some advice here about the use of respiratory viral panels, and that the guidance here really hasn't changed in the COVID era than it was prior to the COVID era, which is that these tests should be reserved for where it's going to change management. The use of respiratory viral panels does absorb resources. Some of those resources, such as swabs and medium, are now under pressure because of the increased testing of COVID-19. And so it remains good, sensible practice to reserve respiratory testing of the other respiratory virals through viral panels based on the fact that it would change your management. If you go to the next slide, you can see we have some data here about testing availability. We are working hard within HCA to bring in a testing strategy so that we are not relying on either state labs or reference labs. And so we have strategies in both the American group and the national group, which might be able to bring some testing in-house. Reference labs are coming online, but as I've mentioned, the time lag is still considerable there. So we're watching this space very carefully, and we'll have updates for you in the near future. So I won't go into these in detail. They're available through our Atlas website, but we do have strategies laid out in terms of where to send COVID-19 testing based on the patient scenario, ER patient versus inpatient, addressing whether you use a respiratory viral panel or not, and then addressing where that test goes, reference lab, state lab, in-house, depending on the situation of the individual facility. The goal in terms of the more public health approach, as you've heard, is the concept of trying to blunt the curve by using protective measures to try and avoid a large spike of patients coming into our facilities. You can see here the red curve is a representation of the steep uptick in cases we would see if we were not doing anything in terms of social distancing or other public health measures to try and influence the transmission of the virus. We're hoping to get to this more spread out curve through protective measures, and that includes the things we're doing in our facilities to protect our healthcare workers. So what we know about transmission is that it is probably particularly through droplet precautions, requiring close person-to-person contact. The rule of thumb by the CDC is that if you are within 6 feet of someone, that increases the odds of transmission. It's typically direct contact with secretions in the form of droplets. It is believed that transmission is increased by being symptomatic, although there is probably some likelihood that just before development of symptoms that people have some ability to shed virus. And if you go to the next slide, some of the triage occurs based on whether there's a history of travel to one of the more prominent geographic areas, and whether there has been contact with other ill patients. There's issues in terms of environmental cleaning and disinfection, which we are using in our facilities, although the take-home for clinicians is that standard environmental cleaning practices are likely, we know they're adequate, and the role of environmental transmission is probably very minimal in comparison to the need for person-to-person transmission. If we go to the next slide here, we have issued treatment guidance for our clinicians, and these will be posted on our Atlas website. The take-home here is that treatment is mostly supportive at this point. There is no accepted, approved treatment in terms of a therapeutic for COVID-19, although there are some experimental therapies which are being investigated, and we comment in terms of what the role for those might be in patients that are severely ill. The two leading candidates are either remdesivir, which is an experimental drug that can be available either through trial or through compassionate release, or chloroquine, which is an old standby drug but is available as well. I want to cover a little bit about what we're doing to protect our workforce. We've obviously spent a lot of time thinking about this, and the good news is there is a science here that we are putting in place, and we believe that we can be protecting our workforce in a rigorous way while at the same time doing what we need to do for our patients. This is just some of the data from the literature that shows things such as the fact that active screening at entrances as we are practicing can prevent transmission within facilities. There's data from some other parts of the world where the first outbreaks were seen, that the use of masks, and by masks I mean either a regular face mask or the N95 mask, both of which we'll talk about in a minute, are protective. That second reference is from a large exposure in Singapore to aerosolizing procedures, and patients were protected with either of those masks. And then there's some examples of patient-to-patient transmission, but healthcare workers seem to have been protected by using the appropriate infection control measures. So core tenets of infection prevention are very workable and successful solutions in the setting of coronavirus. If we go to the next slide, just to cover the HCA approach to some of the things that I've mentioned, we have put active screening in place in all of our facilities. By active screening, I mean that patients and visitors are asked questions at the doorways. We've limited entrances to our doorways, asked those questions to ensure that anybody who has any symptoms that might possibly relate to coronavirus are given a mask upon entry in order to protect our workforce. We've addressed the use of face masks, and as I've said, use of the regular surgical face mask or an N95 appears to be protective, and so CDC guidance, which HCA has adapted, shows that you can use either a regular face mask or the N95, although in the setting of aerosolized procedures such as nebulizer treatment or BiPAP therapy, the recommendation is for an N95 mask, which really is a higher level of protection for that one circumstance. If you go to the next slide, you can see we have codified this into a guidance that, again, is available through our Atlas website, which shows how we have guided our workforce through what type of mask a patient should be wearing in certain situations, what type of room the patient should be in, and what should the healthcare be wearing in terms of PPE, which comes down to a mask, gown, gloves, and also facial protection. And then for those settings involving aerosolized procedures, that the N95 mask is the more important choice. There are differences between SARS-CoV and the flu, and it's important to know that this differentiation should be made. I finally want to be able to point you to our Atlas website in closing. This is the way this site looks right now. It's actually undergoing a revision, so if you go there in the near future, you will see that it looks different like this, designed to be even more user-friendly. But we have set things up so that all the resources that I've just covered are available to you here, should be easy to find, and we certainly want to hear your feedback on what we've shared with you here today. Take your questions and make sure that all your questions around coronavirus are answered. Thank you for being with us here today.
And let me thank you, Dr. Ken Sands, our Chief Epidemiologist and Chief Patient Safety Officer. We'll be back shortly with some questions that have come in from around the system, and we'll look forward to receiving additional questions from you, and we hope to be in communication periodically as guidance changes. Thanks again. Just terrific.
Great to be here.